Good morning and welcome to the session on esophageal motility. What we'll be doing in the next half an hour or so is to review the details of esophageal motility testing in evaluating patients with dysphagia, heartburn, and non-cardiac chest pain, with a focus on the Chicago classification version 4 of esophageal motility disorders. We'll discuss the additional testing modalities that are important in establishing a definitive diagnosis for certain motility disorders and how this testing can help guide therapy. And then we will review the current treatment recommendations for the major esophageal motility disorders. Before we start, though, I'd like to give you a very brief tour of the history of esophageal motility testing, which began actually over 100 years ago, not in a clinical context, but really as an attempt to understand esophageal physiology. So as you can see from this diagram, not a very patient-friendly apparatus. So in the late 1800s, two German physiologists, one of whom was also a physician, tried to study esophageal physiology by having subjects swallow an air-filled balloon that was attached to an external transducer. So it was very primitive, not too much information, but it wasn't until 50 years later that two Boston physicians, Engelfinger and Abbott, used water-filled balloons instead of air-filled balloons for the same purpose. Still, the technology wasn't up to being able to measure the very rapid pressure changes in the esophagus. In the 1950s, there were then some studies using water-filled catheters rather than balloons, which really did provide the beginning of an understanding of esophageal physiology, but not very much use in the clinical setting. And it really wasn't until the 1970s when Ron Arndorfer devised a new low-compliance hydraulic capillary infusion system that we had actually a clinical tool to not only study esophageal physiology, but also a helpful tool in defining some of the motility disorders that possibly had a relationship to symptoms. So it was possible to record esophageal pressure, LES function, and it actually worked fairly well. As you can see, this is the pharyngeal spike, UES relaxation here, a peristaltic wave, and then LES relaxation that is coordinated with the onset of the pharyngeal spike. And this, the capillary infusion system actually generated 6 categories of motility disorders, which you can see here. And some of the labels are familiar. So achalasia, diffuse esophageal spasm, ineffective esophageal motility, but they had different manometric features than what we think of today. And there were several problems with the system. First was that the spatial resolution was very limited. The 7 sensor ports were just scattered across the whole esophagus, so very far apart. The interpretations were subjective. And probably even most important, the motility disorders that were based on the results did not distinguish between symptomatic patients and patients who might just have an abnormal finding on manometry. So in the 1990s, Dr. Ray Clues from WashU actually changed the landscape of esophageal manometry, and he developed a high-resolution, what we now call the high-resolution manometry system. The first iteration was a water perfusion catheters with 21 channels, external transducers. He digitized the information and then assigned colors to esophageal pressures and designed what are called topography maps of esophageal peristalsis. And it wasn't really until the development of the solid state pressure sensors in the high resolution manometry catheter that made it possible to study the esophagus the way we do today. So these 36 sensors that are sensing circumferentially generate a huge amount of data, and they basically capture esophageal motor function in real time. And these data sets are then translated into color topography plots, which are maps of esophageal peristalsis. And this is what you see. This is a normal study. The UES resting pressure is up here. A pharyngeal spike will trigger UES relaxation. So you can see blue color is low pressure, plum is high pressure, and you can see this drop in UES pressure. There's then a peristaltic wave. The gradation in colors has to do with pressure. The proximal third or 1/4 of the esophagus is made up of striated muscle. There's a transition point to the distal 2/3 that's made up of smooth muscle. And then you can see the LES relaxation, again, coordinated with the pharyngeal spike. So it was clear that this was a brand new tool with lots of potential, but a very limited classification of motility disorders. So in 2007, a small group of with international representation of esophageal experts met in Paris to explore the potential of this technology and also to create a standardized approach to motility testing. Their work resulted in the first Chicago classification in 2009, and since then there have been 3 updates based on input from people all over the world using the system and sort of fine-tuning the significance of the findings. And we are now in the Chicago version 4 era. The major power of the Chicago classification was that it created uniform definitions to describe esophageal motility disorders with objective metrics, and very important was that it was focused on clinical relevance. So these are this is the terminology used in the Chicago classification. I just want to briefly review it so we sort of have a common vocabulary. The integrated relaxation pressure, or the IRP, shown here at the bottom, is basically a measure of LES relaxation and resistance to bolus flow through the EGJ. The contractile deceleration point here is the end of the peristaltic wave. It is really used to quantify the distal latency, which is a measure of propagation. And that number is determined by dropping a perpendicular from the pharyngeal spike to the contractile deceleration point. The distal contractile interval, or the DCI, is a measure of the vigor of the distal esophageal contraction, and it's a combination of amplitude, duration, and the length of the contraction. And finally, peristaltic breaks, which are breaks in here between the striated and smooth muscle portion of the esophagus, is a measure of the effectiveness of peristalsis. So any break that's greater than 5 centimeters will affect peristalsis and actually goes into the definition, as we'll see, of ineffective esophageal motility. So the Chicago classification, broadly speaking, divides motility disorders into disorders of EGJ outflow, so achalasia and EGJ outflow obstruction, and disorders of peristalsis. Low peristalsis or ineffective peristalsis, and spastic or hypercontractile changes. This is the flow diagram of a Chicago classification study, but I'm just going to have you take a look at it in a slightly different frame. The first branch point is whether or not the IRP is abnormal. If it is abnormal, and if there's absent peristalsis, it's achalasia. If peristalsis is preserved, it's EGJ outflow obstruction. If the IRP is normal, you then look to assess peristalsis. If the peristalsis is spastic, as in distal esophageal spasm or hypercontractile esophagus, that's the definition. And then if the peristalsis is weak, it's either IEM or absent contractility. The procedure is done by having the patient be semi-supine. They get 10 wet swallows, 30 seconds apart. And then there's a sequence called rapid multiple swallows, which are shown here, 4 swallows with deglutative inhibition, followed by a final swallow. And this is a measure of peristaltic reserve. So if this is a robust contraction, it means that there's adequate peristaltic reserve, regardless of whether the patient has ineffective esophageal motility. And that's important to the surgeons when they're doing anti-reflux surgery, because it's a metric for which patients might potentially develop achalasia, and that influences their choice of the wrap. The second part of the the protocol is to have the patients do 5 wet swallows upright. The reason for that is that some patients with EGJ outflow obstruction will normalize their LES measurements in the upright position, and therefore it's probably the initial reading probably was related to a mechanical change. It could even be related to obesity. The other important innovation in the motility lab is the functional lumen imaging probe, or the FLIP, which is a way of determining the distensibility of the EGJ. And basically the metric that we use is the cross-sectional area over the pressure. So the larger the area and the higher the pressure, the lower the distensibility index. And a very low distensibility index would be seen in patients, for example, with achalasia or EG junction outflow obstruction. There's also another added benefit and component to a FLIP study is called panometry, which is the DI, the EGJ DI, plus the contraction pattern of secondary peristalsis, secondary because it's triggered by balloon distension. And so on the top panel here, you can see a standard motility study, and the lower panel is what you see during a FLIP exam. In patients in a normal study, you see what are called repetitive antegrade contractions. That's normal. In a patient with achalasia type 1, you see no contractions. Achalasia type 2, you initially see some very weak repetitive contractions, and then they sort of fade away. And in type 3 achalasia, you see repetitive contractions, but they're retrograde. So this can be useful as an adjunct to the information you get from the standard FLIP. So turning now to achalasia, there are 3 subtypes. Subtype 1, they all have an elevated IRP. Subtype 1 has all failed peristalsis with no panesophageal pressurization, usually a very dilated esophagus. Type 2 has some esophageal pressurization, usually less than 70 millimeters of mercury, and minimal esophageal dilation. And type 3, again, elevated IRP and evidence of spasm in more than 20% of the swallows. So that means that the pressures can be high and the swallows are usually premature with no normal peristalsis. And typically on a barium study, you might see a corkscrew esophagus. There's been a change now in the way achalasia 2 is being looked at. In fact, and there is a second distinct subtype for achalasia 2 that was described based on the results of a 3-year retrospective study from Chicago of 53 patients with type 2 achalasia who underwent the usual EUS FLIP and barium esophagram. 25% of these patients have what is called segmental elevated pressures. So these are focal elevated pressures, as you can see in this diagram, usually in the distal and in the mid esophagus or the distal esophagus. This is never seen typically in a standard achalasia 2 patient. Some of them also, the ones that don't have focal elevated pressures, will have panesophageal pressurization bands, but the bands are greater than 70 millimeters of mercury. So the thought was that achalasia 2 with so-called FEPs may represent a subtype with spastic features similar to type 3, and this has important implications for treatment. There also are different findings on endoscopic ultrasound, which is now in more common use in the esophagus, and it makes it possible to evaluate the thickness of the inner circular layer of muscle. This is the muscle layer that is involved in peristalsis, as opposed to the outer layer of longitudinal muscle that is responsible for esophageal shortening during a swallow. So what was found in this variant achalasia is that these patients had thickened esophageal circular muscle that extended way up to 10 centimeters above the EGJ. The barium studies were not showing a dilated esophagus, but rather more tertiary contractions. And the treatment outcomes for this subgroup were great with a POEM, but not so great with a Heller or pneumatic dilation. So this really seems to be a more spastic subtype and very similar again to type 3. So how does a clinician choose among the various options in treating achalasia? There are some things that can be helpful. There were 2 important randomized controlled trials that were published in 2019. This one from the New England Journal, an RCT prospective study of POEM versus Heller with a DOR fundoplication. The primary endpoint in all of these studies is clinical success defined by the Eckhart score. And the secondary endpoint, given the concern about reflux with the POEM, was reflux. This study included all 3 types of achalasia, and but it did exclude patients who had previously had surgical treatment, not endoscopic treatment. And what you can see on this slide is that the clinical success was greatest in the beginning, and then there was some decrement for both groups over time, and they extended their study to 2 years. The POEM actually did a little bit better at each juncture than the Heller myotomy. As far as the reflux assessment, as expected, the POEM did not do as well as the Heller, much higher incidence of reflux for the POEM, and at 2 years, the incidence of reflux was not as great for the POEM, but a little bit higher for the Heller. If you look at the data, though, for LA grades C and D, at the 2-year mark, the 2 procedures actually were not that far apart, although the POEM still had a greater incidence of esophagitis. The second RCT was comparing a POEM to pneumatic dilation in patients with treatment-naive achalasia, and they included only patients with types 1 and 2, and they excluded type 3. Same primary endpoint, and they found that the POEM did extremely well at 2 years. And not surprisingly, the pneumatic dilation group did not, but again, they only had 1 dilation, and typically to treat this group adequately, they need more than 1 dilation. And the secondary endpoint of reflux showed a big difference, it's not surprising, between the POEM and pneumatic dilation. For type 3 achalasia, it's very clear that a POEM is the treatment of choice. This is a study from several years ago of 32 consecutive patients with type 3 achalasia, follow-up of mean of 27 months, and the long-term symptom relief was over 90%. And this has been echoed in subsequent studies. This is a study that looked at the follow-up at 5 to 6 years. And this was a Scandinavian study of the first 84 patients who were treated with POEM starting in 2014. The incidence of reflux was assessed with formal pH testing, and 94% had persistent benefit at the 5 to 6 year mark. So it's pretty clear that this is the treatment of choice for type 3 and possibly the variant of type 2 achalasia. So just a quick summary of treatments. Types 1 and 2, pneumatic dilation, Heller, or a POEM are all great options, except for achalasia type 2 with FAPs. Pneumatic dilation is less costly, lower complication rate, but often requires retreatment. POEM has an increased risk of reflux, but may provide a more durable response and also avoids the risk of vagal nerve injury, which can sometimes result in gastroparesis. Type 2 with FAPs should be treated with a POEM. Patients with hernia, moderate to large hiatal hernias, and type 1 or 2, the Heller myotomy is preferable because the partial fundoplication will correct the hernia, which is a benefit. For type 3, POEM is the treatment of choice, and probably the reason it's so successful is that patients get a long myotomy as opposed to what's done typically during a Heller. And so the spastic portion of the lower esophagus is included in that myotomy. And obviously, for patients who are not surgical candidates, Botox is useful. Before we get into the other spastic disorders, I just want to make a couple of comments about chronic opioid use, which has now been clearly associated with spastic motility changes in patients with symptoms. This was an old retrospective study of 121 patients with chronic opioid use. 66 were on opioids, 55 were studied off. And what was clear is that the group with opioids, as you can see, seen in turquoise, had a much higher incidence of EGJ outflow obstruction than the non-opioid group, and the same thing for type 3 achalasia. This was a study, a more recent study of 220 from Mayo of 225 patients taking opioids who had high resolution manometry. 24% had opioid-induced esophageal dysfunction, and this was the spectrum of what they found, mostly distal esophageal spasm and EGJ outflow obstruction. Jackhammer esophagus and achalasia 3 were less common, but still represented. And this is in comparison cohort of patients not on opioids. The prevalence of spastic motility disorders was only 9.5%. So some investigators consider this a new manometric category that's defined as esophageal symptoms with abnormal motility in the context of a minimum of 3 months of chronic opioid use. Just as a side note, dysphagia tends to be the most important symptom, or the most common symptom. The mechanism is a decrease in NO, so it's unopposed excitatory neural stimulation. It results in impaired LES relaxation as in EGJ outflow obstruction, esophageal body contractions that are hypercontractile, premature contractions such as in distal esophageal spasm, or simultaneous contractions as in type 3 achalasia. The management, if possible, is to stop opioids. If that's not possible, then these patients are managed just the way patients with these same disorders are managed who are off opioids. So turning now to EGJ outflow obstruction, this has a very specific definition in the Chicago 4 classification. It requires that the IRP be elevated in both supine and upright positions. So if you have an elevated IRP in the supine position and it's normal in the upright position, it's not considered positive for EGJ outflow. Symptoms have to be present. So if a patient has EGJ outflow but no dysphagia or chest pain, it doesn't matter. It's not considered a significant finding. If the patient has symptoms and has the elevated IRP into a position, you still have to do a confirmatory test to prove that, and the tests are functional tests to prove that this finding matters. And so the confirmation can be either with a timed barium swallow, shown here, that shows a retained column of barium, or a pill remaining at the EGJ for 5 minutes, or using the FLIP technology to show that the distal, that the DI is very low. So the distensibility is low. There are 2 subtypes. One is idiopathic, where there's no obvious reason for the development of EGJ outflow. And then secondary can relate to anything that causes mechanical obstruction, including diverticuli, hernias, strictures, post-surgically related to vagal nerve injury. So patients who have had Nissens, lung transplantation, bariatric surgery can develop this disorder. Infiltrative disorders at the EGJ, sometimes needing endoscopic ultrasound to clarify. And then, as we mentioned, opioids. The treatment is conservative at every juncture. So sometimes the symptoms will resolve spontaneously without any intervention. Medication choices include those that relax smooth muscle, calcium channel blockers, and Botox, or that increase NO, like phosphodiesterase inhibitors, sildenafil being the most commonly used. Third, if you're going to escalate the treatment, it would be a through-the-scope balloon dilation or pneumatic dilation. And finally, for patients with really refractory symptoms, a myotomy. Turning now to the spastic disorders of the esophagus, that is distal esophageal spasm and hypercontractile esophagus. And just like EGJ outflow, they can be a primary motility disorder or secondary related to GERD, vagal nerve injury are the 2 most common causes. And the symptoms are typically the same as we've been looking at for virtually every category: dysphagia, heartburn, or chest pain. And importantly, these disorders can coexist with EGJ outflow. So distal esophageal spasm is a premature contraction. The distal latency is short and the DCI is normal. and the IRP is normal, but it requires symptoms. And if no symptoms are present, then look and see if the patient has GERD. So premature contractions means a short distal latency. The management empirically is, it can just be anti-secretory therapy or formal testing for GERD. Measure medications that increase NO, again, calcium channel blockers or hyoscyamine can be actually very useful in this context. And then surgical treatment for dysphagia, if the patients are very symptomatic and have failed everything else, would be a POEM or a surgical myotomy. Hypercontractile esophagus in Chicago 4 has a new definition, which includes jackhammer esophagus. So there are 3 manometric types. The basic criteria for all of these types is a DCI greater than 8,000. The first type is a single contraction. The second is multiple peaked contractions, which is now called jackhammer esophagus. And the third is a hypercontractile esophagus with LES hypercontraction. The treatment, as I mentioned, is empiric PPIs. If you have a disorder underlying it, treat the disorder like EOE. Calcium channel blockers and the phosphodiesterase inhibitors can often improve the motility tracing, but not necessarily the symptoms. Trazodone is used for pain modulation. And then this, there can often be an important component of visceral hypersensitivity. And so the standard treatments, SNRIs, SSRIs, and TCAs can be used in that context, and endoscopic and surgical management for patients who are refractory. One question is, do any of these patients need to be monitored for the development of achalasia? Because they are really an important subgroup. And in a multi-center retrospective longitudinal study, it turned out that 5.2% of this group with hypercontractile esophagus progressed to, 3 of that group progressed to achalasia over a mean of 2 years. And the only finding that was significant was that the association or the presence of EGJ outflow obstruction at the time of the diagnosis of hypercontractile esophagus, that was the group that progressed to type 3 achalasia. So if you're going to monitor any group, that would be the group to follow more closely. The addition, as I mentioned, to EUS to esophageal testing has been important. And this is a study that very similar to what we saw with standard achalasia type 2 and variant achalasia is that circular muscle thickness will vary among disorders of EGJ outflow and probably indicates a different pathophysiology. So type 3 achalasia and EGJ outflow have thickened circular muscle that extends much higher up the esophagus than type 1 or type 2. The mean distensibility, the distensibility index by FLIP was also lower for achalasia 3 and EGJ outflow. So given the similarities in circular muscle thickness between these groups, EGJ outflow, variant achalasia, and achalasia and type 3, these investigators proposed that together they represent a distinct phenotype, different than achalasia 1 and classic achalasia 2, both of which have much thinner circular muscle and esophageal dilation rather than spasm. So again, the implications for treatment are there. Turning now to the hypocontractile disorders, ineffective esophageal motility is defined as conclusive diagnosis greater than 70% ineffective swallows, meaning failed, weak, or fragmented. And then it's important to do some supplemental testing to show that it has some clinical significance. The treatment is to treat the GERD. And then if it doesn't work, consider a prokinetic, although the choices are very limited. And same thing for dysphagia, prokinetic. And if no benefit, then consider a neuromodulator. Prokinetics for dysphagia, as I said, are limited. The best choice really would be the serotonin agonist. Prucalopride is the one that we have available, which acts in the myenteric plexus. Muscarinic receptor agents act on smooth muscle, and motilin receptor agonists like erythromycin and other macrolides affect the LES primarily rather than esophageal motility. So it's a really limited choice. Absent contractility is usually idiopathic, although it can be related to GERD, usually very severe GERD or a connective tissue disorder. IEM can be found, even severe IEM can be found in asymptomatic patients. Unlike severe IEM, absent contractility is almost always symptomatic, and dysphagia is the major symptom. Despite the fact that they have such, the motility is really absent, they still can have anti-reflux surgery if needed. The choice of the wrap, though, is important, and they would probably not get a 360 wrap. They would get a 270. Sometimes in patients who have absent motility and a normal IRP by motility testing, if there's a concern about achalasia, they would have to have, and that can be a real concern, they would have to have either a time barium esophagram or a flip. And the flip can be abnormal. The distal, the DI can be very low, even if the motility tracing shows a normal IRP, because the sensibility index is a much more sensitive measure for EGJ function than a standard esophageal motility study. And as I said, for this, really nothing will improve motility. So the treatment is just aggressive anti-secretory therapy, lifestyle changes, and coping strategies. A couple of words about a newer motility disorder, which is seen in post-bariatric surgery, patients complaining of dysphagia very commonly. And this can be a complaint that begins several years after the surgery. This was a study of 97 patients. 5.2% of them had this very unique achalasia-like pattern with panesophageal contraction and high pressures in the LES, but related to pressure from intragastric pressure as a result of the surgery. So a very different pathophysiology. And then just one final word about the fact that DGBI, disorders of gut-brain interaction, includes the esophagus. This was a prospective study of over 200 patients in the US and France who filled out a dysphagia questionnaire and an anxiety hypervigilance questionnaire. The question the study was posing was, does hypersensitivity influence the severity of dysphagia? The major motility disorder, it turned out, was a predictor of severity dysphagia, but even with greater predictive value was the esophageal hypervigilance and anxiety score. So it's important to remember that dysphagia severity, whatever the etiology, is amplified by hypervigilance and hypersensitivity, even more so in patients with major motility disorders. So when you see these patients, and it seems as though they're not responding to treatment, think about visceral hypersensitivity in the treatment for that disorder. So in summary, esophageal motility testing has evolved from balloons in the 19th century to a water-perfused catheter system to a high-resolution solid-state system with very sophisticated software. This progression has enabled a better functional definition. Again, the emphasis is on functional because it has to be related to a patient's symptoms. So functional definition of motility disorders as described by the Chicago classification. To be clinically relevant, an abnormal manometry finding requires that symptoms be present, and complete evaluation often involves additional testing beyond manometry, such as EGD, FLIP, time barium esophagram, to demonstrate mechanical abnormalities that confirm the manometry findings and help guide therapy. In patients with dysphagia, obstructive physiology is the primary target of therapy, with POEM being the most widely used surgical procedure. Treatment for non-obstructive dysphagia primarily involves pharmacologic therapy and lifestyle modifications. For some patients with chest pain and dysphagia, especially those with hyper or hypocontractile disorders, neuromodulation is sometimes a part of the treatment just further emphasizing that hypersensitivity can be an important contributor to esophageal symptoms, but also represents another therapeutic target. Thank you very much for your attention.